But kind of why are we here? These are some of the reasons that people said why they wanted a course like this. They wanted to enhance clinical decision-making skills. They love the opportunity for peer-to-peer mentoring. They want to optimize critical thinking and reasoning, and I think that's enhancing our decision-making skills. But I really want to know why you are here. You can put it in the chat, but I want you to be thinking why you are here, because I'm going to come back to this concept, because I know that in my head I have some gaps that I want to improve, or things I put on the back burner, and that there's things I want to implement in the clinic that I haven't implemented in the clinic. So I want you all to be thinking about, what are your needs? We have an ENT, for instance, that will be participating in this course, and his need is he has a lack of vestibular therapists, and so he wants to better understand, I do all these diagnostics, how can I turn that information into treatment? You may have your own need. I'm overwhelmed with what to do with abnormal ocular motor findings. Maybe it's a little bit more about your practice. So any kind of need you have, because that will be our final work group on the lab day, is working together as peer-to-peer mentors, finding solutions to things you can go out in your practice to make you feel more efficient, more confident. Some of the things, the skills that we're going to talk about tonight. And that's the one thing I love, is that the word skill is in there. So clinical thinking, reasoning is a skill that we can become better and better and better at. Okay, so this is just one of many definitions of critical thinking. And you can see that this is even an old reference, but there were some things I took about this one. They're judgments, they're based on well-supported reasoning. We look for flaws in arguments, fosters the ability to be creative and constructive. If everyone in my family is creative, from creative the way we think of creative. My mom's an interior designer. My dad's a builder. My sisters are super creative, and I'm not the creative one. So my new thing in life is I am creative, and in the clinic, it's not what most people think is creative, but it's kind of my creativity. And I do think we have to be creative to be, successful in our clinical thinking and reasoning. And it's about applying new knowledge, being open-minded to new knowledge. But I think that's some of the challenges too, is there's so much knowledge, so much information to process out there. Some other key words that you'll hear is rational logical thought, result in better decisions, problem-solving skills based on reasoned judgments, discipline skill to assess validity of something. And even when Dave emailed me just before we jumped on this call, I know some words in his email that I really loved. And I think what I was reading was, Dave, that you wrote something about scripted deductive reasoning. So I was curious. I'm going to add this. I'd like to add to the conversation of kind of what your thoughts were about scripted deductive reasoning.
Yeah, it's, term came from a colleague of mine, Jim Meadows, and it came out of looking at the different ways we reason and what we do. And, this conversation is the different ways we think. Experts do pattern recognition. They've seen this case come in, 10 times today in the clinic. They know what it is right away. And, what they generally have is 2 or 3 differentials in their mind that they can work through. And they know pretty quickly within 2 or 3 questions that, okay, I'm pretty strong that it's this diagnosis. And then you have to take into account bias, which is another portion of that. But how you teach the new grad, other than just exhaustion of doing every single test and everything and then trying to look at all the information that you've collected and come up with a decision, it's got to be simplified. Because if we go through that process, by the end, we're just overwhelmed by data. And it's hard to make a discernible decision. So you generally just regress to the first thing you thought it was anyway, because you can't sift through it. And there's names for all those, which you don't need to get into right now. But between hypothetical deductive reasoning is an off-branch of script-focused deduction. So as we look at the algorithm that Bridget has in here later on, the algorithm is almost an example you can think of as being, what is script-focused deduction? It's having a list of the 3 to 4 characteristics that are most common in presentation in the conditions you see. So when a patient comes in and we have our top 3 differentials or top 4, we in our mind, if we're new, what we don't have is a list of is here's the things that we should see. And our questioning and examination should then be based on these are the things that are going to either strengthen or refute my differential diagnosis. So it's kind of an off branch of hypothetical deductive reasoning where you capture all that in your mind and your mind has that list. Early on in this process, and that may be like, if you think about like the first certification course, really what you're trying to build from is that script focused deduction where I can have this list of different things that I can test and it can support me, to this course where we're working toward a stronger hypothetical deductive model, the heuristics model. And then eventually over time, you start to develop that bit of pattern recognition, which is that real advanced expert thinking model. And I think is where we're going with this course is that idea that how do we take you from that earlier level of thinking and make that very clean, and then progress you from where maybe we're going from script focused deduction to hypothetical deduction to heuristics, where you're just recognizing these patterns, and then you can select the most appropriate tests to strengthen or refute your differential. And then over time, which would probably be a year or 2 or further on from now, you develop pattern recognition. And there's probably several conditions out there that we all have pattern recognition already for, but it's to bring those other ones up to that level.
And thanks, Dave. And thank you all for sharing your thoughts, because that will be part of, and when I say an end goal, it's just what Dave said. It won't be something we'll accomplish at the end of that day. It'll be something we put together, we develop supporting materials that you can take out into the field, and then we'll see what works and what doesn't work, and we'll continue to refine that. Okay, thanks, Dave. Some characteristics. The reason I chose this, I liked some words in it. I think, some words that really speak to me is, when I think about students that come to the clinic, the first thing we do is get the skills down. Just be able to do this test, this test, this test, and this test. And then we work on interviewing, because that's a little bit harder process. But the earlier we can recognize something, and that recognition may come before you even see the patient. I would say that it needs to come before you see the patient. So if I look at a chart, I'm acting like I do paper charts anymore. I don't. So if I look at a chart and start to see patterns in a past medical history like this, then I'm already developing something. But I have to be aware that that may be biased. But I am still looking for those patterns. And where do they live? What are their demographics? Do they have insurance? Are they paying out of pocket? All of those mean something to me. What's their symptoms? And again, I have to think about my biases towards that. I may have a bias that if someone comes in and it's a workman's comp injury, and that I see that they've seen 17 providers, and then I may have a bias in my head that, okay, is this patient here to see another provider, not to return to work? I can't wrong myself for I may be thinking that, but I have to make sure that I don't use that bias when I assess them. So we have to be aware of our biases.
So Bridget, early in that process, as you're getting that early information, what would you say in the most typical case? What would be your process in that? Do you feel a lot of it's pattern recognition, or is it like that hypothetical deduction where you have this short list of, okay, it's probably these 3 differentials, and is your questioning then specific for those differentials, or do you keep your questions more general?
I would say I become more targeted. So if I see someone has checked, allergies, arthritis, diabetes, thyroid, I'm starting to think inflammatory, auto, and so I want to ask them, where are you? Are your allergies well controlled? Where are you with your thyroid? I talk to them about anything kind of this inflammatory.